The current recommendation is in a young child, maybe somewhere between 2 and 4, that maybe has an ear infection, not too much difficulty. Do you always have to treat an ear infection with antibiotics?
No, the ear infections do not have to be treated with antibiotics. Obviously, 100 years ago, we didn't have antibiotics, and most children got better. The problem is, in those days, there were many more complications from ear infections, such as mastoiditis and meningitis. In Europe, for many years, they have been, I wouldn't say not treating, but not immediately treating ear
Wait and see,
infections.
they call it.
A wait-and-see approach. What that means is that the child is observed for a period of 3 days, and if there is no improvement, the child is then treated with an antibiotic. In the meantime, the child is treated. The child is treated with some form of analgesic, such as acetaminophen or ibuprofen, to help with the fever and help with the symptoms. But if there is no improvement in the status of the child in 3 days, the child should be treated with antibiotics. However, there are certain signs that you look for initially that tell you this is a child who should be treated initially. A child who presents with an acute ear infection with a fever over 102.5, or is in very, very severe pain, or is vomiting at the time of presentation, is most likely going to be treated anyway in 3 days. So a child like that should be treated.
If it's under 2, probably would be more apt to treat it quickly, too.
Yes. Now, there are guidelines that were put forth by initially the New York State Department of Health, and ultimately were adopted by the American Academy of Pediatrics and the American Academy of Otolaryngology, which means ear, nose, and throat specialists. And the general guidelines for observing or taking a wait-and-see approach on an ear infection is that a child who is under 6 months, whether or not you're sure, even if you suspect the child has an ear infection, you should treat it. In a child who is in between 6 months and 2 years, if you are sure about an infection, you probably should treat it as well. If a child is between 6 months and 2 years and you're not sure, and notice I say not sure, it is okay not to be sure. In fact, we're not always sure if a child has an ear infection. Sometimes the child has fluid. Sometimes the child is very uncooperative. Sometimes the child's ear is red because the child is screaming and crying. Sometimes we're not sure. If we're not sure and the child is in between 6 months and 2 years and the child is not very sick, again, not with a high fever, it's okay to watch. If a child is over the age of 2, even if you're certain that there is an ear infection, even if you're certain that the child has acute otitis media, it is okay to take the wait-and-see approach unless, again, the child is very sick with a high fever or vomiting.
So you treat a kid for 10 days, and the 10th day comes back to the doctor. It seems to be okay. If you look in the ear, there's a little bit of fluid left. You don't have to treat again, do you?
In fact, you should not be treating a child at that time. I personally don't see children back for about a month if they seem to be feeling fine. I always tell the parent if the child is not better in 2 or 3 days, I need to be contacted because maybe the antibiotic was inadequate or was the wrong one, or if we have chosen to wait and see, then the child needs to be put on the antibiotic. But if you look at all children, if you look at 100 children 2 weeks after an episode of treated acute otitis media, at 2 weeks, 70% of children will still have fluid. So the majority is still going to have fluid. That doesn't mean there's a problem. That's the natural history of fluid slowly dissipating after an ear infection. If you look at children 4 weeks after initial treatment, 40% will still have fluid. If you look at children 8 weeks after the initial treatment, 20% will still have fluid. And if you look at children 12 weeks after the initial treatment, 10% will still have fluid.
The reason for that is a good reason why it's coming up, because we're getting the impression that we have a limited life of antibiotics to use. If we use them a little more carefully, we might extend the life that we have of these antibiotics, less resistancy. Maybe that MRSA is really linked to overuse of antibiotics. So if we're careful and selective, maybe we get more use of what we have right now. Is that true?
Absolutely. The quoted term now is the judicious use of antibiotics, which means that using an antibiotic when you really suspect a bacterial infection. It goes back to what we said about colds. The child who has a cold, sometimes the parent wants an antibiotic, and we as physicians have to resist that temptation to want to please the parent and say, listen, we have to wait 10 days because if the child is not terribly sick, they can wait 10 days, it'll go away on its own. In the end, the child and the community will be better off. That's the reason why we're now experimenting, or I shouldn't even say experimenting, but trying the wait-and-see approach of not treating every year infection in the proper situation. Again, a child over the age of 2, a child who's not terribly sick, because the less that we use antibiotics, the less resistance there will be.